invitation and inviting me in your course. So this is the my topic is suprachoroidal hematoma and drainage techniques. Sometimes in a lifetime situation, this kind of situation may be faced by every surgeon, every one of us. So intraoperatively, just after cataract extraction, sudden hypotony may induce onset of suprachoroidal hemorrhage. Sometimes it becomes almost painful experience, like everything will be coming out from the your whenever it finds its own weakest way. So this was the video of live demonstration of how expulsive can happen from my own good friend Dr. Subhendu. So I will talk about the drainage techniques as well as the what is the brief idea about the suprachoroidal hemorrhage. It is a rare condition defined as a collection of blood in the suprachoroidal space in between sclera and choroid. The incidence is very rare, 0.04 to 1%. And actually, it is not a space, it is a potential space where there is the normal volume of the suprachoroidal space is 10 microliter of fluid it can accommodate. But when there is any rupture of the any arteriosclerotic vessel or any kind of trauma that can induce the collection of blood in this space. So I will talk about the postoperative suprachoroidal hemorrhage. Predisposing factors reported for the development of SCH includes advanced age, glaucoma, increased axial length, systemic cardiovascular diseases, non-phakic condition, that means aphakia or history of vitreous loss, and current indication of surgical drainage of SCH is extreme pain, a persistent flat anterior chamber, uncontrolled elevation of intraocular pressure, retinal detachment, central choroidal apposition, that means kissing choroidals or retinal vitreous incarceration in the wound, or inability to deposit the intraocular contents. So intraoperatively, just after removal of cataract, the signs of expulsive hemorrhage could be the bulging forward of the iris diaphragm. These are all like these are all warning signs of expulsive hemorrhage. This is going to happen. So vitreous starts swelling out the limbal section, iris will prolapse out, and there is glow will be lost, and seepage of prolapse of vitreous through the wound. So easy breaking of suture while you are closing the wound. So primary management of intra-expulsive hemorrhage, it's a tight closure of the incision, posterior radial sclerotomy that I've already described by Dr. Aditya, and anterior radial sclerotomy that is also possible either in 1 or 2 quadrants, 10 to 12 millimeters posterior to the limbus on either side of the superior muscle. It is very easy to perform. So postoperatively, anytime till 2 weeks. So ideal time for drainage where the clot lysis is happening, that means 7 to 14 days after primary surgery. Within 7 days, if you want to do this surgery, you have to use the help of subretinal suprachoroidal TPA injection for the clot lysis. Otherwise, natural clot lysis is happening. It is happening after 7 days.
Subhendu,
so for the secondary,
sorry to interrupt you.
Yes,
because this is a discussion by interruption. So at this stage, you would do a serial ultrasound.
Yes.
To observe the unless you have recourse to TPA. So answer this question, plus whether you have any experience of using TPA if you have to drain before 14 days, before liquefaction.
No, I have never used TPA for the suprachoroidal hematoma. All the cases are done for the submacular hemorrhage, but for suprachoroidal hemorrhage I have never used. But if people can use it, this is another option. So for secondary management, early referral to peer colleague, he will assess the case and he will do serial ultrasound. Dr. Guha was telling that you have to do the serial ultrasound to go for the evidence of this clot lysis. So surgical management described earlier, it was the radial sclerotomy combined with vitrectomy and use of perfluorocarbon liquid. The standard surgical technique, Dr. Aditya Kelkar has already shown, that's 2 to 3 millimeter sclerotomy. Sometimes and you can introduce cyclodialysis spatula for the better.
How many millimeters from the limbus?
It is the if you are doing anterior sclerotomy, you can do it the parsplannar region, or if you do the posterior sclerotomy, 10 to 12 millimeters away from the limbus.
10 to 12.
Yes.
But vortex veins, any consideration? Vortex veins?
What?
Vortex veins location, any consideration?
Vortex veins that either side of the suprarectus muscle is the ideal site for the drainage. Avoiding the vortex vein is obviously. So use of anterior chamber maintenance and SCH drainage through the anteriorly placed 23 gauge cannula followed by vitrectomy with PFCL and ending with silicone oil. It has already been described by Dr. Rosie T et al. In 3 cases. So our technique was to introduce PFCL from inside, and posterior the passive drainage of suprachoroidal blood. It was our modified technique, and I have used it in our initial 15 cases that we have already published in IGO. This is another, it is one case where I am trying to push it's a very old video using the 23 gauge cannula, and remaining lens matter was there, almost kissing choroidals. Now the choroidals has little bit decreased while doing the surgery. Now I have seen the intraoperative intravitreal picture of the thing, and now you just see the cannula was quite old, and after vitrectomy I am introducing this PFCL, and you can drain the suprachoroidal blood, and you can see the tip of the cannula by using a Sandler's light or by intravitreal illumination. It is not mandatory to drain all the blood, suprachoroidal blood, intraoperatively, and at the end of surgery.
That's very important.
It is not mandatory to use to drain all the suprachoroidal blood. That is, it is mandatory, because rest of the part you have initiated the drainage first, and it will be slowly drain. It should slowly resolve in the course of time.
Do you suture the sclerotomies?
No.
Good.
No, it's absolutely sutureless. So this is another case where this is the post-op picture of the same case, where final BCV obtained after silicone removal logmar 1, that means 6 revision. This is another case where there was squishing choroidals, hyphema, and kissing choroidals, hyphema. I tried to introduce all the ports here, and it is mandatory to see the gas of blood is coming out after the introduction of the left-sided port, and then introduction of this right-handed port is quite cumbersome, because the choroidals is also boggy here in nasal. The temporal side, you can see the maximum elevation. From the maximum elevation, the elevated side, by which was pre-operatively should be guided by the ultrasonography. And just see, I am just draining the blood. After doing vitrectomy, injecting PFCL from inside, and external passive drainage of blood was possible. At the end of surgery, remove all the PFCL bubble and inject silicone oil at the end finally. And you can see there is improvement in the glow, and post-operatively you can see the complete absence of suprachoroidal blood, and ultrasonography patient, although didn't get too much of vision because the choroidals was almost involved. The macular part, it was not, still persisting, and after 3 months of the VCBA, it was showing logmar 1.3, that is 3/60 vision. Silicone removal was not done. So in this case is a one quadrant suprachoroidal and hyphema. So after initiating the surgery with AC maintenance, I tried to
Subhendu, just pause.
Yes.
So just for the sake of the audience, CC, anterior chamber maintainer has such an important place in this, because you do not know the extent of the choroidal detachment interiorly. So safest is to begin with an anterior chamber maintainer to keep up the pressure. And Subhendu, second question, have you tried using Helon? Suppose there is no indication of doing a vitrectomy. Because there would be cases where vitrectomy would not be required. A simple ab external drainage would suffice. In those situations, because once you start using PFCL, you have to do a vitrectomy first and then use PFCL. Without vitrectomy, PFCL cannot be used, as is sometimes the notion among the people who are beginners. So you don't have to do a vitrectomy. In those situations, would you use Helon?
No, I have never used Helon.
Okay.
You can use it. Yeah. Okay. So so I am just draining this black colored suprachoroidal blood, you can see. So after completion of this vitrectomy, I am injecting PFCL and external passive drainage of blood after introducing multiple sutureless, that is no valveless 23 gauge cannula. I am just removing all the black colored blood, and finally I remove the silicone PFCL and injected silicone oil in end of surgery. After 3 months of this surgery, I removed the silicone oil and used gludile for the completion of the case. So after 3 months of, you can see the expulsive is totally gone, and finally patient gained 6/12 vision. So so this is the case. This was the case preoperatively. You can see here you see the preoperative picture, and postoperatively gludile is absolutely centered. Complete absence of suprachoroidal blood in the ultrasonography as well in obtuse picture, and patient gained 6/12 vision. So this is another case, more hemorrhagic kissing choroidals and along with total retinal detachment. Here I am using 3 23 gauge port and one the Chandler's light 25 gauge and checked my infusion whether it is inside or not. You can see the retinal detachment is there, and you can see the slit-like break in the supratemporal quadrant, 2 slit-like breaks. So sometimes it is very much mandatory to mark your break because you will easily miss it. Try to find out the disc is here, not much of PVR. So PVR you may or may not get, and after doing vitrectomy, decent vitrectomy, PVD is usually it is happening in most of the situation. So I'm injecting PFCL and try to drain the subretinal fluid through the same slit-like opening, and while you are removing the subretinal fluid, you can see the actual elevation of the suprachoroidal hematoma. So it was not much at that time, so I try to drain the blood from external side, and you can see after completion of residual vitrectomy and little bit of vitreous base excision, I introduced this port 10 millimeters behind the limbus with the help of 23 gauge null valve cannula. Remove the trocar first and try to drain the blood. Little bit of blood was coming out, and then I settled the retinal detachment, and postoperatively you can see it was the preoperative kissing choroidals. Now postoperatively choroidals has not gone, but still I have not removed the oil in this case, but later on it will be slowly resolved. It will be resolved after 3 years of surgery, because I have used 5000 centistroke silicone oil. After 3 years of surgery I removed the silicone oil, but patient was having
Why did
some
you
kind
use
of
5000?
5000 because not to remove the oil so early, not before 6 months. So after 3 years of surgery I removed the silicone oil, but still the patient was having some kind of hypertonic postoperatively. It was not removing even with diflurednet. So good prognosis case, you should consider 1 or 2 quadrant suprachoroidal hematoma along with the vitreous hemorrhage, not much of retinal detachment, so you can gain good result. And bad prognosis case where the retinal incarceration is there and a lot of like kissing choroidals, these are all bad prognosis case.
Take your time. Take your time.
Yes, retinal incarceration is another thing where your prognosis is not good, because although I have treated the case very well, like in this case, after intervention done after 10 days of surgery and after 3 months also, it is, you can see the post-op picture here. The retina is nicely attached. It was a case of retinal incarceration, but still the patient was having the hypertony, persistent hypertony. For that only I have not removed the silicone oil. So these are all bad prognosis cases. You will not get good result. Thank you.
Thank you, Subhendu. Great. Come.
I have couple of cases more because I after the series in IGO, but I have managed
using the trocar cannula method.
Yes.
Yes.
25 gauge or 23 gauge.
So which one you prefer, 25 or 23?
Today 25 is good enough.
Good enough.
You are getting
only the
non-valve or valve cannula. Yes, valve cannula you can use it in the infusion port, but non-valve cannula you can use it for the drainage.
And also you can remove the valve by a cutter.
Yes.
With a cutter.
Yes.
And get rid of the valve.
Yes.
And then use it for drainage.
Yes.
In case your hospital allows you to cut the valves.
Hospital will allow you. Everybody. Nobody can stop you.